HIV is a manageable disease. But we encourage a lot of people that once they come and commence treatment, it's a manageable condition. It's just like any other disease where people are on lifelong treatment like diabetes and many other conditions. On the clinical front, if someone's viral load is suppressed, the U equals U come in. U equals U means undetectable viral load equals untransmissible. So someone who is HIV positive, who's been on drug for at least 6 months and whose viral load is suppressed will not transmit to their husbands, their wives, and other partners. So it's a very exciting program. People are now understanding the importance of getting the drugs. They're taking their own health into their own hands. And it's a time where a lot of people are now knowing that viral load can be done. And I want to commend the ACTAP for making it possible. We're taking it away from the laboratories and putting it in the facilities. And now we are leaping onto the next platform is to make sure our people who are on the drugs are safe. They're virally suppressed and transmission is prevented.
In the past, we've seen challenges that people face living far away from the health facilities. They come, they're being tested, and the result is not ready. And they go away, and they are lost to follow up. And then when they come back, they're very sick, and we cannot save them. Initially, there were a lot of deaths, but now with the treatment, we are able to keep people living longer. We are progressing in terms of new technologies and new ideas, new innovations. I always embrace those innovations that are coming on board. It shows that if we do viral load testing to the people living with HIV, we can have a big impact in terms of making sure they don't transmit the virus. Doing the point of care testing can also help us to make sure that we test for resistance, making sure we protect our new drugs so we don't risk our drug by people not knowing their viral load status and transmitting the virus which may be resistant to the population.
95% of people who are on the HIV drug needs to be virally suppressed. A very important target in terms of HIV programs. I decided as the chair of the sub-technical working group to lead the group away from the usual normal ways of doing things and start looking at the opportunities out there that can bring home the results. And that's where I think the ACTA plan comes in. Yes, we can step out of our comfort zone and test new things like the GeneXpert platform to do viral load.
We have 2 lab sites established in the country. In Mosby is the Hadro Clinic, and in Mount Hagen is the Tininga Clinic. We have a huge number of people registered on treatment and accessing those 2 centers. At this stage now, viral load testing across the country is not favorable. So having to have ACTA project in this space and contributing immensely in terms of testing a lot of people who are on ART and measuring their viral load and providing this data to the national office sort of like help the country to see how far we are in this space.
It's a job well done in the HIV program, which ACTAP has done to support for this service as a point of care in the clinic. The setup here is basically to provide this vital test to our clients when they come to the clinic to address the turnaround time, to give the results to the clinicians to help them to give counseling to the clients when they come. They know the importance of ART, getting their ART on time to suppress the HIV viral load. We have clients initially tested positive. They will be on ART for 6 months, and then they will come for viral load testing and to see if their viral load is suppressed. We also have them like coming annually for viral load as well. This service is also given to those who have defaulted from ART. If they have high viral load, they also come after they do the adherence counseling. They are used to going home and come back 2 weeks or 3 weeks or a month or to get their results. They are not used to waiting to get the results. So this is a new thing for them. To see if the viral load is high, greater than 1,000, you know, they were like, okay, I think I haven't been drinking my medication properly. That's evidence for them. So they are like, they are not lying. The result is telling the truth. So the clinicians are feeling satisfied that they have something in front of them to console the clients. And like as a technician, I am excited that the test that I am running is going straight to the clients for case management. So getting the result on time, same time is a fantastic, like it's a great milestone for PNG as a whole.
I think having this available is a major advantage for us. We need to know that these babies who are positive, they've got good viral suppression so that, you know, the future life is being decided now in this first space of the year. So having to monitor them and ensuring that they get a good start in life is a good thing for them for the rest of their lives.
Some years back we never had to diagnose the children earlier. So now with the ACTAP program, we've seen some promising results for children who are exposed to HIV positive mothers. With the ACTAP program, we are able to diagnose them early, as early as 6 weeks, and we can even do the viral load to children, which we never used to do that before. And ACTAP has brought that service to the children. We can then plan the ongoing management of children, because we've been losing a lot more children to HIV because we never diagnose them early. If we diagnose them early, they are positive, then we can plan out their management to make sure that they get the appropriate treatment. They come for review, they remain healthy, they can grow up to be healthy children.
My initial experience with the children with HIV was when working on the wards. I came across children who were having opportunistic infections, the advanced HIV, and finding out that they had been waiting for the results for their early infant diagnosis. So seeing the patients on the ward prompted me to put together a look at the data of turnaround time for early infant diagnosis, and we found that it took a long time, a median time of 21 weeks to come, and many of these kids would have stopped their prophylaxis and then they were unprotected if they were HIV positive. So this pushed me to work with the ACTAP program to see if we could get gene expertise so that we could have the test done at 6 weeks, identify these children who needed to be on ART early. So that's where we've sort of basically started, and now we are looking at working in the overall space of the PPCT program, where starting from pregnancy all the way to early infant diagnosis and having the mother-baby pairs tracked until we reach 2 years of age. The issue of the point-of-care testing for children is paramount. And I think all of us need to really be happy that technology is making it possible for us. We don't need to keep people waiting, because one of the biggest challenges, and I think the anecdotal evidence has shown that a lot of mothers, because the results are not coming back, the turnaround time is too long, we are losing them. And in this time and age, in the 21st century, with technology readily available, I think we need to move in those directions, or move into those spaces quickly and try and bring in the results.
But alongside long piginini, even long detecting whether HIV is or not, and me plus a bleeding asylum go, and plenty time. By the time baby I'm developing plenty of opportunistic infections, plenty time me losing all, plenty time I lost to for life. But now me bleeding, that's all just next door. I'm all testing DPS or all testing straight whether HIV is present or not. But as long as you look more positive, now I'm testing treat, so me putting lamarsen. But effect on this lamarsen and walk inside the body and me clear stuff. But me looking more Now I'm this platform start MPMA machine. My goodness, em nam mi plan by put him lo marasen em number you mean look him the mama emi give him marasen long baby this lamb by em nam mi plan by start him me look him by change him scenario long HIV care treatment.
The clinicians, the technicians, we are overwhelmed with MPMA. So it's a first of its kind to have children below the age of 10 years to have access to viral load. Having NPMA on board to have a small amount of blood volume to test for their viral load is a great achievement and a great appreciation to ACTAP to take on this initiative to have MPMA on board on the ground point of care at Well Baby Clinic for the pediatric population.
The turnaround time for the early infant diagnosis and the viral load testing is sort of virtually within the same day. And with the early infant diagnosis, we've had good response from parents. So having those MPMA results available and ensuring that we can be able to tailor the medication accordingly to the patient's needs, that we can be able to have the patient come in, get the results, knows if need be the treatment is modified and adjusted at the same time they come instead of waiting for days or weeks. I commend every other institution that has come on board, and the University of New South Wales, the KB Institute, the Institute of Medical Research, and the leadership provided by National Department to bring everybody on board so that we can try and achieve this important indicator. And I think the Department of Foreign Affairs and Trade Australia has been very good through its many efforts and initiatives. And it's been really great to have this partnership with PNG-IMR and have the ACTAP program, so it's provided us with the resources that we would normally have not had. I think we are really doing a lot of things that are milestones in HIV care in this country with this partnership.
ACTAP is a good team that has like so many collaborators, partners both on a national and international level, because after all, a team that works together goes for the greater good of our population in need. We have very good partners, so they have funded us different with our machines here on the ground to help us with our viral load testing, and they have supported us also up for MPMA. So it has been a very good, good relationship.
I'm very happy with the ACTAP. That was the first of its kind that we were really able to engage and be involved in it. Through the experience from ACTAP, working in the clinics and the PHAs, I think you open up the minds of the clinicians as well as the program managers in those PHAs, embracing those new innovations that will help us to respond to the HIV epidemic. So I'm happy that they are taking ownership of it. Those are the areas that ACTAP has really strengthened in the circle of HIV program in the country as well as internationally.
Islam also kind of some natural programs to HIV to get some like struggles and challenges and stuff. So but now also like helping belong ACTAP, yeah, people are looking service provision platform some kind of some game change. Now people are privileged, but now one time this la viral load platform is stop now. I'm now people stop long good la area long advise him or give him school talk long all people living with HIV. We said stop long margin long, so that all mask is margin good. Plant in nearly all the time now stop undetectable level.
ACTAP is clearing the pathway for greater things to come. So the great initiatives, accelerating and moving on with HIV testing, with HIV services at the clinic, in White House, pediatric population, well baby clinic, antenatal clinic, labor ward, at the wards. ACTAP is pioneering and going towards breaking some of the old traditional, conventional things that we have on the ground with HIVs.
We must be open to change, and we must welcome the input. And I think the important part here is, how do we bring on research to inform. So I'm really proud of this particular program. But actually giving them a number to the picture is words cannot explain. They see that HIV is a manageable condition, and it sort of strengthens the adherence. And I think that's the most important aspect. People are so happy that they have a second chance to live.